Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. Healthy world, healthy nation, healthy you. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today we have a very interesting topic having to do with clinical guidelines. Our topic today and our title is Clinical Pharmacology Guidelines. That has to do with drugs, and we'll talk about the details of that. What are clinical guidelines? How are they used by clinicians, insurers, and what do consumers need to know about them? And our guest today is Linda Relanu. Linda is the president and CEO of Genuine Healthcare Resources. This is a patient advocacy firm, and she works with corporations, and she also runs a wellness firm as part of this. She is a registered nurse, and her master's degree is in management and public administration, and she has a special interest in health policy. Linda is a very experienced nurse, and she's going to tell us about her background, which is very unique because her clinical work has taken her through hospitals, clinics, insurance companies, and through pharmacology companies. So she has a very broad background, which I think really puts her in a very unique position to talk with us about pharmacology guidelines. She's also, in her spare time, school board director of the Westchester, Pennsylvania School District. So, Linda, you mustn't have too many extra minutes in your day. You're a very busy woman, and welcome back.
Thank you. Yes, and I enjoy it all. It's a lot of fun.
That's great.
Yeah.
Well, Linda, this is a very challenging topic about pharmacology clinical guidelines. And before we get into that, tell us about your background.
Well, I've been a registered nurse for over 24 years, and I've worked in Center City Hospitals in Philadelphia. I then moved into the managed care health insurance arena and was there for about 8.5 years. I then moved to the pharmaceutical industry, was there for about 9 years. I was also a director of nursing of a skilled nursing non-medical home care agency. And as you said, I have my master's in public administration, which concentrates in healthcare policy. So I have a pretty vast background in all the diverse players of the healthcare industry.
That's really excellent. And you're putting them to good use now, all those experiences in your advocacy company. And tell us about your advocacy company so people understand what you're doing now with all that experience.
Right, well, Genuine Healthcare Resources is a patient advocacy company. We are all registered nurses, high-functioning registered nurses like myself, where they have various different backgrounds besides just having been a nurse working on the floor. And so we have various different services where individuals can contract with us for very high touch. They need help with mom and dad. They need us to go to the assisted living facility, to the hospital. And then we have a more easier, simpler, what we like to call service, where it's our Genuine Assurance program where individuals can, call in for a nominal fee and just ask whatever question they may have, just because they need to have that little assurance of this is what mom's doing. Dad just went in the hospital. Do you think we're okay? Do we need help? Can we do it on our own? Because some people do want to do it on their own, and I think it's good to help them do it on their own, because then that increases their ability to get better and better and more empowered the more you help them do things on their own.
Right.
So that's one thing I like about the Genuine Assurance program, is it really helps people to start to become empowered, and we just sort of guide them along and they can do it on their own.
Sounds very
without,
good.
A high cost is a very nominal fee for that. Yeah.
Right. Well, I think with that background, what we're going to be focusing in on today are clinical guidelines. And our 3 key points for today are to tell you about what guidelines are so that you understand what they are and how they are used to steer your medical care when you have a condition. The second thing we're going to really emphasize is not only how they're used, but at times how they are not necessarily addressing your issues. So we want to talk about how useful they are and how they really help many people. But if you fall outside of these guidelines, what is your recourse? And the role of your physician, the role of the insurance company that very much monitors the utilization of these guidelines, and then the role that Linda has gotten involved in to help advocate for people that really do need to have care that is outside of these guidelines. Now, the reason I thought Linda was a very unique person to really address this very complicated issue is that she has worked in all of these arenas. It takes a very special skill set to really understand how this actually works inside of all these various organizations. And today we did decide to focus in on drug guidelines, because that way you're really looking at you as the patient. You have the insurance company that is really, again, monitoring which drugs you're going to get for your condition as these guidelines would specify. And then you've got the drug companies who manufacture these drugs. And as you know, we have generic drugs and we have specialty drugs. And they're all different kinds of categories. So we want to simplify this for you. That is the goal of this show, is to really help you have a basic understanding in case you become one of the many hundreds of cases that Linda has dealt with through her company, through her advocacy company, to help people sort out when these are working and when they're not working. So let's start with guidelines. Just give us, level set for us, what guidelines are, how they've evolved, and how they are being used today in healthcare.
Okay. Guidelines can be pulled together from various different individuals or various different organizations, I should say. Sometimes it's the government, the CDC, which is the Center for Disease Control.
Thank you.
They will put together certain guidelines. For instance, one of our clients was pulled in using the guidelines for Lyme's disease because it's an infectious disease, and the CDC monitors its Centers for Disease Control. So sometimes it's the government. Sometimes it could be a certain trade group that specializes in that particular area will pull together guidelines. Guidelines are usually based on research and other peer-reviewed information, which means that peer-reviewed means that a physician or a group in that specialty had to review your group or had to review your research. You couldn't just have anybody. So if you're writing guidelines on a neurological condition, then the outside group that's going to review that also has to have their specialty in neurology. So that's why it means by peer-to-peer, so that we're sure that the guidelines actually fit and work for that particular disease. So various different groups can be creating these guidelines, but they're to be based on research and what's called evidence-based medicine, so that there's actually proof out there that the guidelines do work.
Right. I think that's a very important point, because guidelines, when they were first introduced a couple decades ago, physicians at first were not really advocates of this. They really wanted to practice as they felt were really the best approaches based on their knowledge, training, and experience. But as the healthcare field evolved, and because there was so much more research, there was obviously evidence of things working better than something else. And that's really been the birth of the guideline movement. The guidelines say that for the bell-shaped curve of people in this condition, whether it's diabetes, heart disease, you name it, most people will fall in the middle. And these guidelines, to the best of our knowledge, are the best ways to treat this particular illness or disease. So for physicians today that are getting their training, these guidelines are not cookbook medicine. They are really ways to start a process going. They are tried, true, and tested. But what we want to talk about too is not only how they're utilized effectively, but then what happens if you fall outside of those guidelines, because they were never intended for 100% of the population, because there's just so much variation in people. We know from all the research that's going on with our DNA, genetics, each person is unique. So sometimes the guidelines will not work for you or your situation. And that is really the focus of Linda's work in this area, and really what we are talking about today. So let's walk us through maybe how you got involved with this and sort of how that journey led you to certain cases.
Well, during my time in the managed care arena, you start to see a little bit of some of the pushback when someone wanted to go outside of guidelines. I didn't really have a full understanding of that until I left the managed care arena and then went to work for the pharmaceutical industry. That's when I really started to see where the two can really come and mesh together.
So give us an example of that. That would be very helpful.
Okay, so for instance, we had a child who has a very rare disease, and there is a drug approved for a similar condition that would have worked for her, but it wasn't within the guidelines because it wasn't 100% with all the evidence-based medicine working for her rare condition. So they wanted her to try the medication that was within the guidelines. Well, it didn't work for her because she has this extremely rare condition. Only about maybe 150 people, 180 people on the entire planet have her condition. So we needed to work with the family, with the insurer, with the physicians, to go through the process so that she could eventually be approved to have the medication that was outside the guidelines, because for her within the guidelines just didn't work.
Okay, so the way this would work, I'm learning as I'm having this conversation with Linda as well. So in this case, with this child, her parents were seeking the help of their physician, and the physician wanted to utilize this other drug that would, in his best or her best estimation, be the right match for the symptoms of this. Because of its rarity, there was no guideline per se.
Really, yeah.
So what happens in this case? Does the physician call up the insurance company and have that conversation? Does the family get involved? How does it actually work, Linda?
Well, in this particular situation, which is usually the common situation, the physician and their office staff then try and work with the insurer to appeal the original denial of having access to that drug so that they can have it overturned. Many times, because navigating through an insurance industry, they also have their own language, their own policies and procedures. Sometimes if you don't know how to successfully navigate through that, even a physician can't always get something overturned. And so in this particular case, they went through their first level, it didn't overturn, the denial was upheld, and that's when the family said, okay, before we go any further and we're completely blocked out, we as the family want to hire an advocate to work with the physician. So then we worked with the physician, helping to review medical records, tweaking the letter, bringing out information that was really critical and important, wording it the way you would want it to go through the insurance industry, and then through some conversations with them, we actually had conversations with the insurance company, we're then able to work through and have it overturned. Because not all doctors are insurance savvy. They became physicians to help people, to help the sick and those who are infirmed, not exactly to be, you know, administratively savvy, and that can be quite difficult and cumbersome. Right. So we were able to sort of help them, so, you know, pave that way through for that overturn.
So you're telling me that the way the process works is that when the physician understands that what they want to do does not fit into this guideline. In this case, there wasn't even a guideline to really use because of the rarity of the condition. The burden of proof for why something else would be needed at that moment rests on the physician.
Yes.
So how the physician would put together the argument for why A isn't going to work and B is a better option really has to be written very clearly and convincingly for the insurance company to change their view on this rather than uphold their standard.
Exactly.
Okay. Now, I think what Linda is saying is that, and it's true, most physicians do not get training in this area. Maybe they are currently in certain areas. I'm not familiar with that. That would be new news, and it would be very interesting if they were. But in this case, they really had to ask you, who has this very specific and precise expertise, to help them put that proof letter together. Okay. And that proof letter worked.
Yes.
Okay. And what was the outcome, the clinical outcome for this particular patient?
It's been successful because part of the situation would have been is she would have lost her sight. It was because of the type of rare disease. And now that she's on this medication, we've been able to preserve her sight.
Okay. So that's really a very positive outcome for everyone involved. And I think that this is part of what we're discussing, how this gets negotiated and how does conflict get resolved, because there's conflict in so many areas of life in general. Obviously there's conflict in healthcare situations as well. So give us another example. That was a good example. Give us another example of kinds of things that you are confronting in your practice.
Okay. Another medication situation that we have going on currently is where we have an individual who needs a very specific type of mental health medication. And the person has been on the medication for approximately 4 years. Guidelines changed, and so they decided now that they're no longer going to cover the medication.
This is the insurance company.
This is the insurance company, right, has decided that given the change in their guidelines and their policies and procedures, they're no longer going to cover the medication now after 4 years, which means then the individual would pay out of pocket. The issue is, though, is that the person really needs this medication in order to be able to function. Because when he's not on the medication, he can't function at all. He can't work, he can't do anything. He just sits at home. He's just not able to function and would potentially become a ward of the state because he would not be able to work. And so right now, this particular one is in process so that we can go through the same process as we did before, as far as working through the guidelines, working with the insurer, getting the right information together, so that we can talk with the insurer about what this would mean to the individual, because I think we would all agree that it would be much better if the person could work.
Right. Now, in terms of these guidelines, and as you said, they're evidence-based and evidence grows and it changes. In that particular case, since there was this experience, and I'm sure he's not the only person out there that was on this medication doing well enough that it was really a stabilizing situation, which is the goal of a lot of these chronic illnesses, whether they're mental health or physical health. You're not going to change the underlying illness. You're going to manage the symptoms, and if people are functioning, that's successful. So was that because the guidelines were reflective of new knowledge? Do they give any rationale for these changes? How does that work inside the organization?
Inside the organization, sometimes it could be a little difficult. We're right now in the process of trying to figure out why now, after the 4 years, are you pulling back? So that's part of the negotiation, that's part of the conversation with them to figure out what is different now versus before, especially when a medication is working. You usually do want to have a little bit more than just, due to our new policies and procedures, we will no longer be covering X. You need to know more than just that. So we're in the process of gathering that information so we can figure out what the best next steps are. And I will say we have a lot, and I know this is part of a broader conversation for another time probably, but we have a lot of individuals with mental health issues. Because I think today we all recognize that our mental health in this country isn't exactly the best. So he's one of many that we have coming through the door who have issues accessing a lot of different things from a mental health perspective.
Okay, so that may be a whole other conversation in itself in terms of really how to get access to the right services, access to the right medications, and again with the goal of stabilization. So in terms of guidelines in general, do we know what percentage of the population guidelines really do cover?
As of right now, I think the perception is that guidelines should cover most of the population. I think what we're finding out, and the research is newer now, is that maybe not most of the population. Maybe it could be a 70-30, maybe it could be a 50-50. So what we tell people are, and we agree too with physicians, where you begin with the guidelines. It's always a nice place to begin, because it's guidelines, it's evidence-based, and it gives you a good starting point that has been proven to work in the past. And then if you start to fall out of those guidelines, that's when you need to start having those discussions. It doesn't hurt to start with the guidelines first, because there's no reason to become concerned until you find that, okay, we started with the guidelines, we've been following all the protocols or what you've told us to say, but now things aren't working right. So now we need to start looking outside the guidelines. Right.
So I think that's an important point as well to bring out in our discussion, that guidelines are a starting point, and that is really through the experience of whether the patient is really monitoring their own health. We've brought this out in other shows, that if you are getting a treatment or a medication, you must take it, because as you can hear in this discussion, if you're not following through, guideline or no guideline, your treatment team really can't monitor your success or lack thereof unless you are following the course of treatment. But let's take the positive approach. We're assuming that you are following the recommended course of treatment and you're doing very well in complying with that. But the bottom line in this case example is that you're not getting the results, and your physician and treatment team are noting that you're not getting the results. Mm-hmm. That alone can be enough evidence that something else has to be tried. And when the something else does not fall within that guideline, I mean, there may be other alternatives that fall within the guidelines. They don't necessarily have just one thing. There's a range of things that can be tried, but maybe the range is relatively narrow in a particular case, and the treatment team really wants to try something else. Then that's when you're really, again, falling outside of these guidelines, and that is when this negotiation has to take place. Now, it seems that if it's 50-50, meaning the guidelines fit 50%, maybe the other 50%, okay, but maybe quite a few people really aren't getting much of a response. It would seem like the physicians would be spending much of their time writing these rebuttal letters and mm-hmm. really trying to get the guidelines overturned. What's the experience of physicians in your experience?
What we've found to this point is that many of the physicians, they don't mind having the guidelines out there as a resource and as a great starting point. What they find very taxing on them is when the guidelines are tying their hands and they can see, because they're watching their patient, right? As we were talking about before, you're taking your medications, the team is watching you, they're tracking, seeing how you're doing, and then all of a sudden you see that the person is falling outside of the guidelines. That's when it gets taxing for them, because then it's harder for them to use their clinical judgment, because they're seeing the person slowly fall out of those guidelines, and now that means a lot more paperwork, a lot more administrative work, and a lot more negotiating, because at that point it does almost become like you have to prove a case in a court of law. You have to have all your ducks in a row, you have to have everything lined up, because the insurance company wants to see and be sure that you're not just jumping outside of the guidelines, right. That you actually have tried other things, and that you can actually document that the person is falling outside of the guidelines. Mm-hmm. But that becomes very taxing when it's more than maybe just one patient in an office that's falling out of the guidelines. Right. That can become very administratively difficult.
Plus, there's only one of you. I don't think there are too many nurses or physicians or people with very good clinical backgrounds that have worked in an insurance company and understand drug companies as well. I mean, that's a pretty unique skill set. So what's the track record on these letters that physicians are writing to the insurance company? I'm not sure that anybody keeps track of all that, but what's your sense of how successful this negotiation can be if they don't have someone in an advocacy role like you are playing in these right. cases? What sort of is the general outcome?
The general consensus we're hearing is that they feel as if they're not doing too well on their own trying to get these overturned. But you're right, no one's really doing the analysis, so we really don't know for sure. There could be groups in other states that are doing phenomenally well because those physicians have just worked together and have learned how to get through it. But just at least in this area, the physicians that we're talking to, the hospitals that we're talking to, they feel that it's difficult and that it's not always easy, and they're not always getting them overturned as they would like.
Right. How about physicians? I mean, when they're talking to the insurance companies or mm-hmm. writing these letters, are they talking to advocates like yourself that work inside of the insurance companies, or are they talking to the medical directors? Because having worked in an insurance company myself, there is a chief medical officer, and right. then there are regional or local medical directors, depends right. on the organizational model, but there are physicians and nurses who work inside these insurance companies. So what are their roles peer-to-peer?
Usually the way it would work when we're talking with physicians, many times when they first start out with the phone call, they're usually dealing with one of the nurses on the telephone, on the phone queue. When it's being denied and they want to work on getting it overturned, that's usually when the physician will talk to another medical director, and that's considered a peer-to-peer review. Right. So this way the one physician is talking to another physician, and of course they can speak the same language, so he's walking through with the medical director why he thinks this particular, why she thinks this particular case falls outside their guidelines. And that usually happens after the physician has done their first appeal and it was denied. So now, okay, I sent in all my paperwork as my, physician appeal, it was denied. Okay, now I need to talk to a medical director because I need to make sure maybe they missed something in the paperwork, or maybe I didn't word it correctly. So now let me talk to them, and then they can do a peer-to-peer. When a member calls, a member cannot do a peer-to-peer with a medical director. It's actually very rare.
A member is a consumer.
I'm sorry, the consumer, right, the patient. Rarely, if ever, gets to talk to a medical director unless they're actually in a final level appeal. They actually rarely get to talk to a nurse also in these situations. They usually have to go through what's called member services because you're considered a member of the insurer. So you talk to member services. Sometimes you can talk to a nurse or case manager, which is why it's good to have the physician call, because the physician can call straight and talk to a medical director. And that usually works out much better.
But it sounds like even with that peer-to-peer conversation, they still really have to go through this formal process.
Yeah, when the physician calls to speak to a medical director, and this is where we find a lot of physicians don't realize that, because as we said, this isn't what their training is. They're trained to take care of people. Is before they make the call, they need to treat it almost like any other case, where they need to have their argument and all their ducks in a row and everything all lined out when they go to make that call. They can't just run out of seeing a patient and then just wing it on the phone, because that's usually not when you're going to get it overturned. It's usually when you have your argument laid out, you know exactly where the medical director's coming from, so that you can deal with their objections and you can sit there and actually negotiate. You have to prep for that type of phone call. Yeah.
So there is a very clear administrative process when we're using the words appeal, denial. This is really a very important administrative review that has implications for your health, wellness, and your ability to move through an illness. So what is your recommendation to consumers? Should they wait for their physician to do some of this work with them? Do they work with their physician, or do you sometimes see where patients and families themselves have to sort of take the lead?
Many times the patient and families have to take the lead, especially if the physician has already done their first level appeal as a physician and it's been denied. That's usually when we would say the family should probably step in and take a little bit more of the lead. Maybe reach out and hire an advocate such as ourselves, because we won't only work with the family, we work with the physician as well, because the physician has all the clinical information. And then all of us work together to make sure that we have that laid out. So the gauge, I would say, is if the physician can't get it approved the first time around, always remembering you can only go through this process once as the patient. If the physician goes through and it doesn't work, that's the time maybe to seek help and sort of maybe take a little bit more reins on yourself to make sure you've got people involved.
So there are really a number of key players involved in this discussion such as this. You've got yourself, you the consumer, patient, family. You've got the physician or treatment team. It could be more than one person. And then you've got the insurance company. And in some cases, the pharmacology piece of this is the drug companies and what are the best drugs for your particular case. We're not talking only about guidelines for drugs, but that was the focus of this particular discussion today. I think that this whole administrative process is an eye-opener in terms of how complex the healthcare system can get at times. You may be involved with this. The purpose of this show is really today to help you navigate more effectively, and to recognize that there are times when you can rely on your physician as the lead, and there may be times where it is really a good value to get an advocate to work with you and the physician. It is a burdensome process. It has a lot of administrative wrinkles to it, but I think that listening to this today, I've certainly learned about some more detail on the complexity and the role that you can take. So you should know about your guidelines. You should ask your physician what guidelines that are being used to really help you with your case. And if you're not responding to that, what is the recourse? I want to thank you, Linda, for really helping us. It is an eye-opener to have a discussion like this, to really understand the nuances of your practice and the kinds of things that you've gotten involved in as a nurse advocate. And I want to applaud Linda for using such diverse background to really help people, and to really help people get the best care that they can with the system that we have here in the United States. Thank you very much for being with us today, and have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening and join us again. And remember, with health, all things are possible.